Hello everyone, my name is Renat Haptitime and we are pleased to present our research on comprehensive characterization of genomic, transcriptomic and proteomic profile of MUC1 in breast cancer. Imagine two patients diagnosed with the same type of breast cancers, receiving the same treatment. One responds well and recovers, while the other develops aggressive disease and poor clinical outcomes. Now the question is, what really explains these differences? Breast cancer is the most common cancer affecting women worldwide, yet not all patients experience it the same way. Younger patients, particularly those diagnosed under the age of 40, often present with more aggressive tumors and poorer clinical outcomes. At a stage of life when they are trying to build their careers or create families, this creates a heavy emotional and physical burden. However, the current clinical markers are not fully sufficient to explain why these differences occur, highlighting the need to explore the molecular mechanism behind it.
Hi, my name is Halima Bashir and I'm going to talk about the role of MUC1 in breast cancer and the research gap it addresses. First, breast cancer is well studied and MUC1 is known to be overexpressed in many cancers. You can think of MUC1 as a kind of surface flag on cells. In normal cell, it has a protective role, but in cancer cell, it becomes abnormal and also contribute to tumor progression. However, despite it being well studied, the role of MUC1 in age-related differences in breast cancer is still unknown. This leads to our key research question: what molecular factors drive differences between younger and older breast cancer patients? We focus on MUC1 as a candidate factor because it influences tumor behavior. Specifically, it is unknown how MUC1 expression differs between patients under 40 and over 40, and how this affects clinical outcomes. This gap is important because MUC1 is associated with increased tumor growth, spread, and treatment resistance. So age-related differences may also impact prognosis and influence treatment decision. Therefore, our study aims to investigate MUC1 in breast cancer patients under 40. We will analyze gene expression, genomic changes, and assess their relationship with survival outcome, overall survival, disease-free survival, and reoccurrence. So to do this, we will use bioinformatics, which involves studying the genetic data and with computer-based methods.
Hi, I'm Shada. I'll be explaining about the objective and methodology. We want to answer one question. Can MUC1 tell us something we do not already know? To address this, our study aimed to investigate how MUC1 expression differs between younger and older breast cancer patients, and how these differences related to disease outcome. We uses a multi-omics approach integrating genomic, transcriptomic, and proteomic data. Using publicly available dataset, we group patients based on age and analyze differences in gene expression, mutation pattern, protein level, and a survival outcome. This workflow allows us to systematically explore how age influences molecular behavior in breast cancer with a specific focus on MUC1.
Hello everyone, my name is Hibatullah. So when we transitioned to the data analysis, our primary objective was to quantify exactly how MUC1 expression shifts as the healthy cell becomes malignant. The first real breakthrough came from our transcriptomic analysis. If you look at the stark contrast in the box plot, the reality is undeniable. We observed a dramatic and statistically significant upregulation. The median expression level of MUC1 gene in breast cancer tissue is approximately 8.8, which is approximately 1.5 times higher than the median of 6.2 found in healthy tissues. But here is what truly changed our thinking. The story becomes even more compelling when we look at the distribution across different cancer subtypes. As shown in the cBioportal bar chart, the MUC1 alteration are not uniform. Our analysis found that the highest frequency of these alteration, at a striking 15%, occurs in invasive mixed mucinous carcinomas, while other types like the lobular and the ductal carcinomas shows a slightly lower frequency of 9 to 10%. A consistent and alarming trend emerged, and almost every subtypes, this alteration happened through amplification rather than simple mutation. This is a critical distinction, and it is highlighted in our oncoprint analysis. While the visual is dense, it reveals a profound mechanism. In approximately 10% of the cases, mucin 1 undergoes copy number amplification. Essentially, the tumor isn't just mutating, it is physically replicating the gene to create extra blueprint, actively driving the aggressive cellular growth. We can actually see the consequences of the genetic override physically in the immunohistochemical staining images, and the contrast is staggering. The normal breast tissue displays very weak and sparse mucin 1 protein, but in the malignant samples, the protein is completely saturated, showing high intensity staining that spreads across the entire tumor area. The genetic amplification we found is successfully translating into a massive physical protein shield for the cancer. Finally, we had to ask, how does this molecular chaos impact the patient? And we performed a Kaplan-Meier survival analysis on a cohort of nearly 500 patients. The results were statistically profound. However, this is where the data challenged our assumption. It showed a hazard ratio of 0.73, indicating that the higher mucin 1 level correlated with better survival in this specific dataset. This unexpected paradox demonstrates that the mucin 1 rule in the body is highly complex, and it is heavily dependent on factors we are still actively investigating, such as the patient age and specific molecular subtypes.
Hello, my name is Hiba Taha and I'm going to be speaking today about the conclusion part. To start with, what we found gave us a real reason to investigate this marker further. Here's why. When we integrated data across multiple levels, including gene expression, protein expression, and clinical outcomes, a constant pattern emerged linking the mucin 1 to more aggressive disease characteristics. It brings us back to the patient that we introduced at the beginning. Understanding these molecular differences is important because it may help explain why those younger patients often they face a worsened outcome, and it could also guide the development of a more personalized age-informed treatment strategies. Ultimately, our study highlights the importance of considering age as a biological factor in cancer, and it also positions mucin 1 as a potential marker for improving prognosis and the therapeutic decision. For the younger patients, the understanding mucin 1 it may turn a hidden biology into earlier risk recognition and a more precise care. Our findings also showed that the higher mucin 1 expression in the breast cancer tissue than in the normal tissue, and that the survival analysis suggested that the mucin 1 may have a prognostic value. The alteration data further showed that the mucin 1 is affected across several subtypes of the cancer, breast cancer specifically, which supports the relevance beyond a single tumor group.